March and April, there was justifiably real concern that the pandemic, the kind of core of the pandemic was in care homes. Practices moved to providing weekly check-ins and much more structured support to care homes, and each care home has an identified GP clinical lead who links with that home to make sure they get the support they need. Like the rest of the country, practices had to reorganise and change their premises. So I think we more or less ran the country out of perspex, didn't we, or haven't we? But practices have done the same thing, put in screens, changed the kind of flow through their practices, set up early and late clinics. In some cases, they've had to kind of knock through walls or put in a special kind of extensions or specific bits of building to make sure that they can be COVID secure. As I mentioned, we moved to a digital approach, so we've distributed hundreds of, in fact, if not thousands of laptops to staff so they can work remotely. And Duncan needs to take a great deal of credit for this, but we set up a kind of war cabinet, a team of people that was not just the CCG, which is the NHS body, but also GPs themselves. So the kind of GP leadership team that Duncan heads work with the CCG and with the local medical committee in a daily briefing and a daily meeting to coordinate our overall response and to communicate with general practice. We set up daily calls with those primary care networks so that we could make sure we were linking in with them. Move to the next slide, please. This is Duncan's slide actually about Duncan's practice, but it does reflect what happens. So you get a sense of it. As you can see, face-to-face activity dropped significantly over the initial COVID. As you can remember, people stopped going out, stopped going to their practice, and at the same time, telephone activity rose significantly. People during the height of COVID in the lockdown stopped coming in. Emergency activity really fell through the floor, both in general practice but also in the acute hospitals. You remember those pictures on the telly of empty A&E departments, but overall activities remained relatively constant, although the nature of that activity has changed. Next slide. Is this my slide, Duncan, or yours?
It was me. I was going to just talk about sort of where we are now in general practice and what some of our focus is at the moment. So that COVID activity that we were seeing and the general infectious disease activity decreased through early summer, and very quickly general practice in Derbyshire started to focus on the catch up. And particularly the catch up on people with sort of complex long-term conditions or with significant health needs, and in other areas which I'll go on and cover. And practices have remained open and are still open for business. In terms of just crude numbers of appointments, we're seeing about 91% of the appointments which we were seeing in the same time last year. And just over half of those are face-to-face appointments. So this idea of GPs not working in practice just doesn't manifest itself as true when we look at these huge numbers of appointments. I think what's really important when we consider that 91% compared to last year is actually the average length of appointment has also increased. So we are spending longer with our patients on the phone or face to face to try and really get to the bottom and sort out those problems. And then with the move to triage and with the sort of need to maintain some sort of continuity of delivery of our service, access to general practice has actually improved. So we are seeing more people and speaking to more people on the day that they contact the surgery than we've ever done before, and we've seen that increase by 10%, which is really fantastic. Clive has kindly included a slide which is the sort of overlying the high level data that we get across Derby and Derbyshire, comparing August to August. So can we just go on to the next slide, please? And so in terms of what we're focusing on, so what my day is looking like at the moment, so much like any business across the whole country, we have some real issues around maintaining infection control. So our waiting rooms, I have to manage the number of people in there, so I can't have crowded waiting rooms. I don't want people hanging around for too long. I need to clean the room after everyone's been in it to make sure that I'm not going to pass the infection from one person on to the next person that I'm seeing. And that has a real impact on our overall capacity to be able to see people face to face. And then in addition to that, we also have the same problem that every other business has around maintaining business continuity. So that's the idea of us being able to keep our doors open and keep providing care to people. And that's the same challenge everyone has around self-isolation, because a household member has symptoms, and we've saw some real pressure within general practice through September and now into October with staff members with almost no notice not being able to come in. But in spite of that, we're really focusing on some specific areas. So as I'm sure everyone's aware, we saw a reduction in the number of sort of cancer referrals that occurred through the early phase of the pandemic. So there is a real focus in general practice about supporting early cancer diagnosis, working with the CCG to look at those cancer pathways, and really making sure that we catch up on some of the screening programs that we might provide, like cervical screening. As Clive rightly described, we are maintaining and continuing to improve our support to care homes. We are referring as we would usually refer, so very clear our instructions through this has been to maintain our referrals into hospitals for that more specialised treatment. And then we're looking at people who might suffer from some inequality of health outcome, so particularly people with learning disabilities and particularly people with more complex and multiple long-term conditions, and then reviewing those at risk. And now we're also trying to look forward. So we're anticipating a slightly challenging winter. We've heard the political announcements around social distancing, which won't have the same impact as a full lockdown had. And so we will see continued activity with this additional flu and COVID activity on top. So we are sort of coming up with our contingency plans, looking at how we might redeploy these hubs if we need to, and particularly making sure we make flu vaccination as safe and as easy to take up as possible across Derbyshire. Can we go on to the next slide? And I think this is Clive's final slide.
Yeah, thank you. And I think this final slide wrap up, and then we'll got questions. And I think some of the questions are relevant to this slide actually. So I think it's fair to say at the moment practices are open, but it's not business as usual, as it's not business as usual for any of us. As Duncan's already alluded to, practices have reduced capacity. We're really focusing on catching up and supporting the most vulnerable groups of people in our communities, and managing through winter, really surviving the winter, surviving the potential COVID surges to come. Practices aren't, nobody in practices is immune from COVID, and we've got, in fact, at the moment, we've got 3 practices who have had significant chunks of their staff having to self-isolate, and with staff outbreaks. So we've got a situation where those practices, of course, have had to reduce their services. Other practices have had to jump in to help, and we're trying to manage that at the same time. In terms of what it'll look like, what COVID's taught us, I think it is fair to say that in many ways, although it's been a terrible thing, it has been a transformative experience as well. It's taught us some of the things that we wanted to do, we were talking about and have talked about for years and never done. It's kind of forced us to do those now. So it's taught us that clinical work can be done remotely. It's taught us that you can actually see, you can triage patients on the phone. You can speak to people on the phone. People don't mind being spoken to on the phone. There's lots of sensible things that you can do on the phone. But it's also taught us that that's not you know, that's not an answer to capacity. That takes as long as face to face, and it's sometimes more difficult. So you of course need to be able to see people, and you need to recognise that whilst it changes what you can do, it doesn't necessarily reduce the workload. Yeah, as I say, some people will need face to face, and we will return when we can to provide. Well, we are currently providing for those who need it face to face, and we will return to. I'm sure we will return to more face to face as the restrictions ease as we get through this. However, we shouldn't lose track of the fact. We shouldn't lose the opportunity really to continue some of the work that we've done on telephone online appointments. We've seen that it can improve access, and we've seen that it can release time for face-to-face appointments for those who most need it. So I think that it gives us a real opportunity, and it has shown us what can be done if needs be, and we wouldn't want to lose some of that. And I think one of the things that really can be done is that practices can work together. That, you know, practice, the culture of practices, and I'm sure Duncan can talk about this with more feeling, but the culture of practices has always been very individual. You know, they're individual businesses, small businesses working with autonomy as advocates for their patients. They haven't been keen in the past to work together really, and there hasn't felt like there's a need, but we have shown that where they can, and when they do, they can, you know, work together efficiently and effectively for whole groups of people. So I think we would want to build or continue to build on that. I'll stop there. I think that's us. I think probably the best thing now is if we ask, perhaps we could pick up some of the questions on the chat, and then we could have you know, more.
Clive, the first one came from Andrew, and it was just, is our model of care with the GP surgeries and the hospitals the same in other countries, or do they all have very different models of care? I'm
happy to pick that one up, Clive.
Oh, yeah,
thank you.
So firstly, I think it's important. I don't have any particular political affiliation, but I try and avoid politics as much as I can, but I do have some opinions. So I will share those as best I can. And I've spent quite a lot of time looking at international models of health, because what we know is that primary care and general practice in particular has a huge impact on the overall health of a population. So if we look at the international literature, and even literature that looks specifically at in the UK, we see a 6% reduction in mortality, so the number of people dying, for every extra GP you have per 10,000 patients, and that's been replicated across the world. So in terms of model, internationally, the idea of having a strong primary care is seen as the best way to improve the overall health of a population. So you see the best overall population health in a health service model that has a strong primary care sector. And if you look at models that are trying to improve or that have improved, they've invested more in primary care, and that then sees better overall outcomes. Some of the things that make the NHS slightly unique compared to NHS models is that the GP holds most of the information about a patient's care. So if we make a referral to hospital, the letter comes back to general practice and isn't particularly held in isolation by that hospital. So if you go to somewhere like the US, or where there's a more commercial market, particularly around hospital-based care, we see a very scattered approach to that information, and so it never really sits well around an individual person. The second area that's really interesting about sort of UK-based and the NHS-based primary care is that it's a very broad definition for a single amount of money. So it's this for people that are ill or believe themselves to be ill, for a fixed amount of money in a year. And whereas in other areas, so if we go to somewhere like Australia, they are paid for each consultation they might have with an individual. That will drive patterns of behaviour that are then more financially profitable for those people. And we will see there are some games that can be played within UK NHS general practice, but broadly, this idea of having strong primary care is the internationally evidence-based sort of most effective way of improving health outcomes, and is what is sort of the trend internationally to move towards strengthening that, but it isn't the only model. It's perhaps one of the cheaper models, I think. I don't know if you wanted to add anything to that, Clive.
No, I mean, exactly. I don't have as much experience as you, but yes, I completely agree. I mean, Barbara Starfield, who's a leading academic in this, has pointed to the kind of health benefit, the public health benefit of having strong primary care. And if you look at indexes of kind of efficient health service models, our model has, it's brilliant actually. Our model in how it allocates funding equitably. It doesn't always feel equitable to us, but it is actually internationally a good model for allocating funding equitably. And one of the drivers for that is that strong general practice element. The only other thing I'd say is our model puts a lot of pressure onto general practice. General practice is the kind of pivot point, isn't it? It's the kind of gatekeeper to other services, and it's also the first line of defence. And as we've seen, there's 500,000 appointments just in Derbyshire, and and there's a fraction of that in ED. So although we talk a lot about A&E and ED, and it's really important, those services are really important, the numbers they see are tiny compared to the number that are seen in general practice, and a kind of tiny, a butterfly flaps its wings in general practice and you get a tsunami in the ED department. So we do need to look after our GP.
Thank you very much. We've got Clive, could I just ask you very quickly to just give a response to the question about PCNs, perhaps explain what they are, and then is that all right? Just quickly.
Yeah, so I like that idea that so I think the idea that they're kind of cartels of private businesses. In one sense, that's true. They are. I mean, as we've said, practices are independent businesses, so these are groups of independent businesses. I think the cartel thing assumes that they're in some way monopolising the market and skewing it to their own favour, which I would say is not really the way to frame it. I think I'd say they are groups of independent businesses that we are trying to bring together, not just because we think that there's benefit in them coming together, but also we think that they can potentially then link in with other organisations, so the Mental Health Trust, Adult Social Care, Community Services, the voluntary sector, around a population of people. So if you take a town like Chesterfield, you get all of your practices in Chesterfield, you get the voluntary sector in Chesterfield, you get the mental health services in Chesterfield, and you get some of the acute team in Chesterfield. You get them to come together and you say, as a group, can you look at the population of Chesterfield as a whole and work out amongst yourselves how best to provide a service? And that's the idea, not just because they're better, stronger together sometimes and more resilient, but because they can then work with other organisations as well.
And Clive, it's perhaps worth also noting that there are a number of safeguards. So general practice tends to get a fairly bad time in the press. But if we think about the safeguards to prevent this happening, the partners, so the owners of the business, have to declare their annual earnings, and that's declared on each practice's website. The majority of the funding into PCNs is going into direct salary reimbursement, which comes after the salary has already been paid. So it doesn't come in advance. So there isn't actually a way of making profit out of the additional staff that we're going to see within PCNs, because it's coming as a staff reimbursement. And so this idea of operating to their own ends is really interesting as a concept, and I quite like the challenge, and so that's why it's so important that we have safeguards that sit within it to prevent that challenge or that reality ever occurring as well.
And thank you. Duncan, there's a question from Patricia. Do you expect to maintain current pattern of service post-COVID?
I'm not 100% sure I completely understand the question. I'm going to make the assumption that the question is around the balance of remote delivery of services with triage and face-to-face delivery, with the addition of things like e-consult, which is the online consultation. So that's the assumption I'll make based on that question. I think what we've definitely seen is a group of patients really valuing the remote delivery of service. So that really fitting with their lifestyle and being particularly convenient for them. I think we've seen another group that really like the idea of online consultations. So the idea of being able to, at whatever time of day, ask a practice of their sort of primary care service. And so those elements I see as being really valued, and I can't see those disappearing. So having a responsive remote delivery of service, I think we will see continue. I also think we will see us maintaining a focus on those most in need. So if I think over the last few years, we've spoken a lot about health inequalities, and it's a word that's bandied around, but what it really means is people that don't get as good an outcome in their health compared to other people. And I think we will continue to see ourselves focus disproportionately on those that really need that additional primary care service. Clive, I don't know if you want to come in.
Yeah, thank you. I just wanted to say, going back to thinking about internationally, there's some suggestion or evidence that a kind of safe level of people that a GP can speak to in a day is about 25. So they talk about 25 kind of contacts. And Duncan, you can speak with more authority on this, but we have routinely GP seeing 45, 50, having 45 or 50 contacts in a day, sometimes in a morning if it's busy. And we have a kind of culture, and to some degree practices have a business practices that mean that they think that they need to direct things towards towards the GPs themselves. And what it means then is that, for every 100 people, 80 of us might get to see the GP, but actually only 20 of us really need to see the GP. So the GPs get kind of swamped by people who they can manage, but takes a lot of capacity, and it would be much better in the future. We should be using this opportunity really to shift that a bit, to direct people away from the GP if they don't need to see the GP, but make sure and give the GPs the time to see those complex people that they do need to see. So that's the opportunity really in all of this, that opportunity to kind of shift things around, and that's what we should be really building on.
Thank you very much, and I'll go to you both. I don't know if you want to go first, Duncan. Julie's asked, how have GP services coped with the impact of mental health within their population going forward with increased anxiety and the economic burdens? What support do you think might be available?
I think Julie's question is absolutely brilliant, because it's one of the prime anxieties that we've experienced as sort of running practices and primary cares. Very early on, we recognised that this is going to be a significant challenge. We know the socio-economic stress that people are experiencing. We experience that within our own families, and the psychological toll that has, in addition to lockdown, in addition to not having as access to your friends, the insecurity around work. So absolutely recognising it is really important, and making sure that this really isn't just a general practice thing. We as a society and as a whole health system have to respond to it. We saw very early on in the pandemic a Derbyshire-wide mental health support line, which operates 24/7, and that's the details of that are pretty easily accessible, but we'd be more than happy to provide those. So that's something that people can access, and that's provided by our mental health trust across Derbyshire. So we are also then looking into next year. So from April 21, PCNs are going to be able to look to employ mental health workers. So we will be able to get some additional workforce in to support that. We've got social prescribers operating and employed at a PCN level, and those social prescribers particularly are looking at things like loneliness and at social isolation, which we know are really strong drivers for mental health problems. But I think I would the essence of Julie's question is that there is an issue around the general mental health of the population, and it's an issue that we're really aware of and trying to work hard to continue supporting it. But it is going to be one of our shared challenges over the next few years as we see the impact of this showing through. Mm.
Okay, Katie, you're on mute. Are you?
Sorry, Clive, did you want to add anything?
No, I think that's absolutely right. I think the only thing positive on that is that one of the things that primary care networks are going to get funding for is mental health workers. So from next year, practices we'll be able to recruit mental health workers, which should help. I mean, there's a bigger challenge, I suppose, which is where are we going to get these mental health workers from and how are we going to train them up? But nevertheless, it's a positive that hopefully will help mitigate some of those concerns. But I mean, the country's going to be struggling, I think, with the long-term effects of this pandemic for years to come, and that's one of them.
Thank you. And Megan's asked, are you confident that if Derby moves into a high second surge, you have the right resources in place, for example, PPE available?
I'm nervous, I think I would say. I think I think we did brilliantly. You know, the country did, the NHS did, general practice in Derbyshire did brilliantly in that first surge. But winter is going to be harder. Winter's always harder. And then you've got potentially the surge on top. We're seeing, you know, we're unlikely to have the same kind of lockdown that we did. And actually, if you look at the activity over in March, what happened was people, as we saw in the graphs, people stopped coming out altogether. So general practice then did get a bit of capacity to do the urgent stuff. You could have a kind of perfect storm where activity stays high because people get sick because it's winter. With non-COVID things, people aren't going to be locked down in the same way, so they will be expecting to do their normal things, and quite understandably. And then at the same time, you get COVID coming through, so it could be a bit of a perfect storm. On the plus side, though, obviously we're more prepared for it. People are more used to it. Some of the things that we'll need in place, like the IT and the kind of digital response, are now in place. Practices, the primary care networks are used to working together, so all of that's in place. We've got a way of accessing PPE, which, you know, is in place. But I think it's still a, you know, I don't think anybody's feeling. It would be hubristic, wouldn't it, to say we're ready. I think we have done and are doing everything we can, and we've got everything crossed to try and get through.
Thank you.
I think what I'm confident is that we've got an amazing group of people, an amazing community that all rally around to support each other when the going gets tough, and we've seen that through the last few months. So I'm absolutely confident in that's absolutely there. I'm also confident that safety won't be our primary concern, and when we were in March and April, safety was the biggest concern that we had as staff in general practice. We were really struggling to operate in a safe way. So I think those really fundamental needs aren't there. What we're going to want to do is be able to deliver a brilliant service, maintain that service, and manage the surge in COVID. And I think that's the concern that Clive expresses, is it is going to get tough. But I have the confidence that we have to be okay, because we always will be, and that we will all come together as a community, as we have done, and show our resilience and strength through that.
Okay.
And sorry, the other thing I'd say is the general practice model we talked about, independent businesses, has its frustrations, and goodness knows I know trying to manage GPs is famously like trying to herd cats, and it can be extremely challenging. You've got all the 112 people very used to being, you know, their own bosses, their own advocates for their own patients. But what is brilliant about it is they're very resilient, they're very engaged. They're very kind of, it's their business and they will not see it fail. They're their patients and they will not let them down. So that means that they're very strong, very adaptable. So that's a real positive thing.
Thank you very much. Duncan, just a really quick one, because we've already touched on this. Julie said e-consultations have been a fantastic service, but with over 300 a day, is this still manageable going forwards?
No, it's not. If we maintain a conventional model of care, if you've got a single person trying to review 300 e-consults a day, that's not a sustainable model. What that tells us, and what we need to do as general practice, is respond to that need. So if that's what's happening, we need to change our service to respond to that. So if there is a desire and a real demand for access in that way, we as sort of the people trying to support the delivery of that service need to listen to the people that are trying to use our service and respond and adapt our sort of model of care to suit that. And we need to make sure we do that in a way that then doesn't have a negative knock-on effect to another population of people. So perhaps those that are more digitally excluded, we wouldn't want to see their sort of access suffered just so that we can service these 300 e-consults a day. So I think the question almost is suggesting, well, actually, if that's what we're hearing from our population, if that's the demand from our population, then we will have to remodel our traditional approach to service delivery to adjust for that.
Okay, thank you. Clive, we have a question from Jocelyn about there's public representation through all levels of the healthcare except PCNs. Would you just like to comment on whether there are plans to have that, or?
Yeah, no, I think the question here is about how will patients see into, how will they be represented on primary care networks as they develop, and I think it's a fair challenge that we at the moment primary care networks they're not structures, they're not organizations, they're not entities as such, they're groups of people. They haven't got a contract formally as such. They're groups of practices, so we haven't got the same kind of legal infrastructure or kind of governance infrastructure around them as we have with other parts of the health service. But it is a decent challenge without that. And the good thing about that is that means they're not too bureaucratic. They can kind of respond, and they're relatively new, so they can find their feet. The bad thing, as Jocelyn and John are saying, is potentially that can mean that they can be quite opaque, can't they? You can't get in, you don't know what's happening, you don't know who's making those decisions. So I think, Katie, this is your kind of area of expertise, isn't it? But I would say we need to be, and we will be, pushing primary care networks to be transparent between themselves, transparent to the CCG, and transparent to the public. We will be advising them and supporting them to get public input through, networks of PPGs or PPG representation onto their governance structures as they develop. So I think that needs to happen, and I think the key to probity, the key to good governance is transparency. So we do need that to happen. And I agree that without that, there'll be a gap, won't there, which people won't be able to see into, and decisions will get made, and people will think, well, I don't know who made that decision and why they said that. I think the only other thing I'd say is, at the moment, only on the 1st of October did primary care networks actually have anything to do. It was only on the 1st of October that they got their first services commission from them. So it's very, it's really this month that it's started. So it's still quite new, and it's still a work in progress.
Okay, thank you. Duncan, Andrew's asked, are there any plans to increase the basic NHS mental healthy counselling ration of 6 hours? Not everyone can afford to go privately.
Yeah, so I suppose it's a little bit out of my remit to talk about sort of overall commissioning and mental health services. I think this refers to the IAPT service, which is access to the psychological therapies. As far as I'm aware, it can be for up to sort of 8 to 12 sessions. And that's the evidence-based treatment course. And so people can have repeated treatments with a therapy like cognitive behavioural therapy. But from a clinical perspective, long-term psychotherapy doesn't show significant additional benefit. So there is a benefit to a defined and fixed period of treatment, then having a break from that treatment to then perhaps redo that again in 6 months' time. So I think if I understand the question correctly, it's around the access to IAP and it being a limited and defined treatment period rather than an ongoing treatment. And that's because that's where the evidence seems to sit for cognitive behavioural therapy.
All right.
I think though it is fair to say, isn't there, nobody would disagree that we have a shortage, that we need more capacity in primary and community mental health, and that's partly the drive for mental health workers. There's another requirement for the CCG called parity of esteem, where the CCG has got to maintain investment and increase investment in mental health services, and that needs to be directed, I would argue, and I'm sure we would all argue, towards community and primary care services as well. So it's something that nationally they're aware of, and locally we need to push more investment towards.
Thank you very much. So if anyone's got a final question, if you'd like to put it into the chat box now, and just in the meantime, I will say that the next session is in November. It's on November the 5th, and it's urgent and emergency care. So details of that will be coming out. So if there are no more questions, I'd just like to thank Clive and Duncan for both attending today, and thank you all to you for joining as well, and I hope you're able to join us for our next session. Duncan, there's a lot of activity about your hair, which does look lovely, which I don't know if everyone can see, but thank you very much. I know you're both very busy at the moment with winter planning, so thank you for joining us today, and thank you to everybody else as well who's joined today. Thank you.
Thanks very much.
Thank you very much.
Everyone.
Cheers.
Bye.
Thank you. Bye.
Thank you.